clinical instructor of doctors of physical therapy students. His doctoral thesis is on supercapsular reconstruction, and I may say he's also a supercapsular reconstruction patient, so I'm very looking forward to seeing his personal experience with the procedure. Next, we have Dr. Alan Hirahara, orthopedic surgeon. He's the medical director and head team physician for Sacramento State Athletics and the Sacramento River Cats. He also publishes his research and teaches internationally. And it's not often we get a treat to speak to the creator of a specific procedure, but he's actually the creator of the superior capsular reconstruction with dermal allograft. So he's going to give us some great insight as to this, how this procedure started and how it's been going. And lastly, we have Dr. Michael Leathers. He's fellowship trained in sports medicine and shoulder surgery. He's expertise in joint replacement of the shoulder, and he's a team physician for Christian Brothers high school football team. He's going to give a lecture tonight on shoulder replacement. We're looking forward to that as well. Our objectives, we're going to start off by describing how physical therapy can improve the cuff-deficient shoulder. Next, we're going to discuss the history of superior capsular reconstruction, present the options to treat massive irreparable rotator cuff tears, and the last lecture will explain the indications for reverse shoulder arthroplasty, show how better outcomes are achieved with 3D planning technology. So with that, I'm going to turn it over to Robert to start his first lecture. I hope everybody enjoys this and has a good time tonight.
All right, thank you, Dr. Pinero. I'm going to go ahead and share my screen here this evening. I'm Robert Asuncion, Doctorate of Physical Therapy. I'd first like to thank Dr. Pinero for the fabulous introduction, as well as Dr. Alan Hirahara and Dr. Michael Leathers for inviting me to be on this panel this evening. So let me go ahead and share my screen as we get started. All right, this evening, we're obviously talking about orthopedic options for massive irreparable rotator cuff tears. But what role do I play in this? Well, I'm out here in Sacramento, California. We specialize in orthopedic management of surgical conditions, including SCRs and reverse total shoulders. I have no disclosures for this talk, but we're more going to talk about conservative management of the rotator cuff tears and repairs. So first thing to consider is we want to consider the profile of our patient. Age. And when I'm talking about age, I'm not talking about the age of the client, but necessarily the age of the tissue. So is this tissue thinned out, beat up? Is it robust? We also want to look at the nature of the injury. Is this an atraumatic injury that's happened over time, or is this more of a traumatic slip and fall where we have an acute rupture? And then we need to look at the patient's activity level. Is this patient a patient who is very active, exercises 4 to 5 days a week, or is this someone who goes to work, likes a little light gardening, and so we don't necessarily have to worry about a lot of overhead activity? So we look at a couple of patient scenarios. Here's my 73-year-old active male. He works on a cruise ship, mainly doing office type work. He slipped and fell while he was on the cruise ship, fracturing his humerus, as well as tearing his rotator cuff completely. His goal is to return to walking and cruising, literally. Versus our other patient, who is a 55-year-old former pro baseball player, many microtraumas throughout his career, and he ended up developing a massive rotator cuff tear. He can still play golf and hit the ball a ton and has no pain with that, but he does have pain with simple ADLs like washing his hair and or actually pulling the golf club out of the golf bag. So who's going to benefit from therapy? Well, let's take a look at that. We have found in the Moon Group study, where they looked at 452 patients with massive rotator cuff tear. They participated in a 6 to 12 week physical therapy intervention, and the non-operative physical therapy was 75% effective in getting them back to their normal level of function. That additional 25% went on to have surgery, unfortunately. In the Gutierrez study, they also looked at manual therapy with specific exercises and found that their DASH score decreased over a 12-week period, as well as their VAS score decreased. So we had definitely decreases in pain. Furthermore, in a study by Brauman et al. In 2013 and a follow-up study in 2018, found a rotator cuff quality of life index showing 75% of positive outcomes at the 3 and 5 year marker for non-surgical folks with conservative management. And then a systematic review in 2018 out of Stanford showed that moderate level of evidence to support that exercise therapy to manage full thickness rotator cuff was important. and it should be the first line of management in folks over the age of 60 with chronic and degenerative full thickness tears. So that leads us to the role of the therapist. Well, we're going to talk a little bit about how we non-operatively manage these folks, and it boils down to the philosophy of treatment. So first and foremost, we want to focus on education, educating the patient on what to expect, on how to reduce pain, how to restore range of motion, how to then strengthen appropriately, and then activities that will modify their daily living. So patient education. First, we talked about determining those patients' need in their first counseling visit, determine their level of function and the goals they want to achieve. But more importantly, we may want to focus on the inflammatory process and gentle range of motion exercises in the beginning phase. So we instruct them on that because those first 2 to 4 weeks establishes how they will respond to the therapies afterwards. And then we teach them how to manage their signs and symptoms, as well as set realistic expectations and educate them on the healing process. So how do we reduce pain and swelling? Well, the number one thing for us is if they're having pain, moderate and constant, then they may be doing more damage. And so we want to eliminate those activities right off the bat. Oftentimes shutting down our folks in the beginning phase of therapy and starting on some gentle range of motions with swelling control as the primary muscle pump. We implement things like game ready, power plays, and ice compression devices to reduce their inflammatory response, as well as, if indicated per the doctor, some anti-inflammatories. Then we focus on restoration of range of motion, where we do a systematic approach of looking at glenohumeral and scapulothoracic positioning through the use of manual therapy to decrease pain and spasm and reduce the hypertonic muscle. We move into joint mobilizations. Like we see on the left, we're doing some of our proprioceptive neuromuscular facilitation to help center the humeral head in the glenoid. And then we'll do specific stretching posteriorly and inferiorly to increase capsular mobility. Moving on to some then home exercise programs to maintain that range of motion. Second to last, we'll work on strengthening, and this is balance of strengthening. So we're focusing on rotator cuff strength as well as the surrounding musculature, as it's paramount to their global training program. So we'll focus on rotator cuff strengthening. Be cautious of the infraspinatus as it may be incorporated in part of the massive cuff tear, as the doctors will talk about. And then we get the surrounding musculature involved. And there was some good research by Dr. Levy, which said anterior deltoid strengthening becomes paramount in a non-functioning rotator cuff. So we look at kind of the exercises that we would start them on, moving from a laying down position to a gravity assist position, and then ultimately a resistive position. Last part is activity modification and functional mobility training. So we assess their goals, and the goals are simply to reduce pain, reduce the substitution involved, as well as return them to normal level of function. We ascertain the patient's functional level prior to. So our gentleman on the left is a firefighter and a nurse who had a rotator cuff tear, and we're focusing on strengthening those muscles below 90 degrees, working on keeping the elbows close to the side, so not extended, and also limiting the amount of repetitive work he may have to do after he's called to a fire. In summary, our focus is going to be on early intervention of physical therapy to show both the clinical and statistical evidence that it reduces pain, improves range of motion, and increases function. PT, unfortunately, will not prevent further damage, but it may slow the effects, allowing a patient to get back to their normal level of function. Our therapists focus on having set realistic goals for the patient to return them to their previous level of function, and possibly, if that fails, to optimize them for surgery. And if you look at the left-hand side here on the slide, this is one of my reverse total shoulder patients who's 4 months out. He's got great range of motion at this point. Standing next to him is myself, obviously going through the same motions, and I had an SCR from a massive cuff tear. And the two things that are happening right now is that we're both pain-free. I'm able to lift overhead without pain anymore and throw a baseball without pain, as well as this gentleman now is able to return to his labor type job with modifications, but doing it without pain. So I'd say thank you very much. I'm going to turn this back over to Dr. Pinero, and we'll get going from there.
Thank you, Robert. That was an excellent presentation. Obviously, I think physical therapy is very important preoperatively and postoperatively as well. Next, as we mentioned, we're going to turn it over to Dr. Alan Hirahar, and he's going to be chatting about Supercapsular Reconstruction. Alan, thank you for being with us.
Thanks, Alberto. So I think the biggest thing that I want to kind of talk about tonight was just what is the superior capsular reconstruction, because the SCR is a new relative idea and concept, and some people may not have actually heard about it till now. These are my disclosures. Now, massive rotator cuff tears are specific. We're not talking about these small rotator cuff tears like this here. This is a small tear. It's not going to really interrupt the function of the cuff, really. It's not going to make the change in the actual glenohumeral joint. Even if you have a really large tear like this that isn't retracted, this isn't truly a massive cuff tear because the humeral head will still stay down. What we're talking about is this not just big tear, but retracted tear that's going to have a functional impact on the shoulder, where there's going to be a functional deficit and problem with the shoulder itself. So here you can see in this MRI that the rotator cuff tendon has a retracted back, but in addition to that, we've lost superior restraint. And that's kind of the key to the whole thing, is that that humeral head is now touching on the acromion. It is out of the glenoid. The glenoid no longer houses that humeral head. That humeral head has to be down lower for it to function. So you're pivoting on the superior glenoid. And what's going to happen is that you're going to have a problem functionally with the shoulder where it's not going to work, and it's going to be hurting because now you're pivoting off of the bone, not the socket itself. So the options for irreparable rotator cuff tears classically were very limited. We could do debridement, biceps tenotomy, partial repairs, even lat dorsi transfers or interposition patch grafting has been promoted, but none of these have done very well. The outcomes from this has been very poor. More recently, we have the bursacoacromial reconstruction by Matt Ravenscroft in England. We have the lower trap transfer with allograft from Bassam El Hassan out in Boston, Harvard. And also the reverse arthroplasty has been the only thing we could really do to reliably have a good outcome. But the problem is it's an arthroplasty. And what are we going to do for those younger patients, those patients that can't necessarily go on and have a reverse arthroplasty at the age of 40 or 50? That was a problem. And so you're dooming people to have a replacement and then potential revisions, complications. There's a problem. So basically we came up with this idea of superior capsular reconstruction. So it started with actual Teruhisu Mahada. Now, Dr. Mahada in 2007 started researching and found that Dr. Hanada in Japan in 1993 first published on the SCR, but no one really paid much attention to it. And in Japan, there was no option for reverse arthroplasty. It didn't exist. So they had to have some other option for these massive irreparable cuff tears. And the whole idea for him was to recenter the humeral head back into the socket using the fascia lata, so an autograft taken and brought down. And in 2013, Dr. Mahada published on his 24 shoulders over 2 years using an autograft fascia lata to restrict that humeral head and keep it down and reestablish a superior restraint, a superior capsule. He found that the acromiohumeral distance went from 4.6, which was very small, to a better 8.7. And ASCS functional score went from 23 all the way up to 93. And 84 of his patients did very well with no tearing of the tendon or graft afterwards. Well, that's what was interesting. In 2013, he actually was at one of my courses I was teaching in LA, and I got to meet him. He had just published his paper. And so I remember distinctly at this course, looking at him going, so Teru, I don't get it. It doesn't make sense to me. And so we went to dinner, and 2 hours later, and after they had just flown from Japan and had not had time to even go to the hotel to change, we went and had a 2-hour discussion about the SCR. And he convinced me. He convinced me that this was something that actually could work, that actually the SCR theory of reducing that superior translation, reducing escape of the humeral head, decreasing the impingement, recentering that head in the glenoid, allowing the deltoid and those other muscles to function was real, and it could work. But the problem that I had is that he would then go and harvest the fascia lata. He would make over a 10 to 12 centimeter incision in the thigh. And he admitted that most of the patient's complications and problems was related to the harvest of the fascia lata. And I thought there has to be a better way, because this is a really bad part of the procedure, that there's got to be something else we can do. And so I turned to dermal allograft. This is basically skin that's been prepared and sterilized. And I'd had a lot of experience with it in the past doing augmentations. This was a good option. It was sterile. Most of the DNA was removed, which would allow it to have less chance that it was going to actually have some kind of reaction. And it was thick. I found out that there was a 3 millimeter thick graft, which I could use. And so then I went to the lab to test it. We found when we used Mahada's technique, it was actually a weak structure. And that's why he needed 6 to 9 millimeter thickness, double and triple over, because it failed at 180 newtons. Whereas the dermal allograft I was using basically wasn't failing. It actually popped the bone block at 550 newtons. So we went in and found a good technique that was going to work reliably arthroscopically. And after looking at it, we were finding that actually this graft was very much restoring stability. And as you can see here in a cadaver, after we've cut the graft in place, you can see just how unstable that shoulder is. So that graft can clearly hold that glenohumeral joint in place. But we found there was a difference because we learned a lot from Teru about fascia lata. It was stiffer. It had decreased pull-through strength. It had to be thick, 6 to 9 millimeter thick. And it had to be harvested. Whereas the dermal allografts were elastic. They had better pull-through strength, but they could be thinner. So it was all about technique. We learned that the technique really mattered. And so in 2015, I published the first technique on SCR with dermal allograft. We found that the clinical outcomes were outstanding. Our patients were doing very, very well. And this really took off. And we found our clinical outcomes mirrored almost exactly what Teru was showing in Japan. Our outcomes were almost identical in numbers in our AH distances, our pain scores, and our functional scores. So we published in 2017 our 2-year SCR clinical outcomes, the only other 2-year data that was available besides Teru's, that mirrored essentially his exact numbers, but just using dermal allograft without the need to harvest the fascia lata. In fact, here's my first case. We had a patient who could barely elevate to forward elevation to 90 degrees actively. She was a school teacher. She was going to have to retire because she couldn't write on the board anymore. And here she is 5 years later, still working as a teacher, back to work, just having some limited overhead endurance, basically doing super well and very happy. Preoperatively, before surgery, she had essentially no cuff. She'd had about 2 or 3 surgeries trying to repair a badly torn rotator cuff that just wasn't working. And with surgery, when we went in to take care of her surgery, you can see she had these massive holes and deficit of bone because of the numerous surgeries she had trying to repair that lost cuff. But we were able to get the SCR in, and she did really well. In fact, what's interesting is that 5 years later on x-rays, there's no advancement of arthritis. 5 years later on MRI, the graft is still intact, doing very well. And 5 years later, that 3 millimeter graft that we put in has actually been expanded out to 4 millimeters. It's thickened and gotten thicker based off ultrasound evaluation. Her outcomes, as I said, very good. Her functional scores, her pain scale, her age distance, her thickness, all looking very nice. And what's interesting is the reversal of the pseudoparalysis. She couldn't lift her arm above 90, but there was nothing wrong with her nerves, and the muscles were there. And theoretically, overhead activity is related to deltoid use, not necessarily the supraspinatus. And this is an example of one of the patients from Dr. Burkhardt, who shows that basically this gentleman could not lift his arm until he had an SCR done. And what's interesting is both Dr. Mahada and Dr. Burkhardt have published papers showing the SCR is able to reverse pseudoparalysis and able to reestablish function of the shoulder. In 2019, the 3 of us did in New York at the American Shoulder and Elbow Society annual meeting, an instructional course lecture together on SCR. And it was very interesting to hear everyone's response that this is something that could be a game changer for patients. In 2018, Dr. Letterman out of Phoenix and I published another paper about the keys to success because we found it was very important that the technique mattered. It wasn't the same as fascia lata, so we couldn't necessarily listen to all the other data that was looked at. It turned out that not just patient selection mattered, but the tension of the graft was critically important. If you over-tensioned it, you got a very bad outcome with increasing pain. If you under-tensioned it, it didn't work as if it wasn't there. This is not a spacer, it's a stabilizer. So it's not just to shove graft in there, it's going to work. You've got to shove the graft in there and make sure it's tensioned correctly so the shoulder can function. Dr. Letterman showed us that he had explanted some graft that he had implanted in a patient who had a failure from water skiing accident. And it turned out on evaluation of the graft that the blood vessels had reestablished. So he had integration and vascularity. He had the tendon-like structure reforming within the graft. He had recellularization and fibrocartilage formation on the side where it was actually holding the head down, showing that this graft was not just dead tissue. It could reestablish, revascularize, and recellularize and be functional and viable for the long term. It would not just fade away and go away as some people proposed. So in 2019, we published a particle on our ultrasound evaluation showing that the graft did hypertrophy. It did get bigger over time. It didn't get smaller or go away. It actually got bigger. We also proved that there was vascularity, that actually it was in fact reestablishing blood flow and becoming a part of that person, actually showing what Dr. Letterman had also showed us. This is also corroborated on further follow-up second studies, as Julie Bishop showed us in Ohio. But this has gotten to be even more than just for irreparable cuffs. We're finding that we have had poor outcomes classically on cuff repairs that were massive cuffs. We found that if we did an SCR first, we were then able to bring that cuff all the way over sometimes and do a full repair and get a better outcome. And what we're seeing is that if we are able to do a full repair on top of an SCR, our outcomes are even better. Our pain scales are better, our functional outcomes are better, and our AH distances are better. So if we can reestablish a cuff, these patients can have even better outcome. So the SCR has given us an option, which we never had before, but the indications are critical. These are for massive cuff tears that have a poor chance of healing. It's for failed conservative management, intolerable shoulder pain, subjectively unacceptable dysfunction, but minimal glenohumeral arthritis. So if there's moderate to severe arthropathy, you shouldn't do an SCR. And that's where Mike's going to talk to us about what the next option should be. There's bone defects, absence of muscular function, or shoulder stiffness, as Robert has said. It's not going to have a good outcome. So that's where these people need to go and do therapy first before we consider doing these surgeries. And that's where Robert's work can be critical in the success of the surgery. In summary, you're going to get excellent outcomes out of SCRs with the proper indications. They'll burn no bridges. They're going to give us minimal risk and complications, but the patient selection will be critical. And more importantly, the technique will be critical. How you do it, making sure that the tension is appropriate and right. Under tension and over tension is going to give you bad outcomes. So the surgical application of the technique really matters. Thank you very much.
Fascinating stuff, Dr. Hirahara. Excellent presentation. I know that I have a ton of questions. I want to encourage all our viewers. You can get on the chat or on the Q&A button and start putting your questions. We are going to have a Q&A at the very end. Without further ado, I want to represent Dr. Michael Leathers. I'm very excited about his talk because I really want to hear about the 3D computer planning on these reconstructions. So with that, here's Dr. Michael Leathers for shoulder replacement talk.
All right. All right, thank you, Alberto. Hope everyone can see the screen here. All right, so I'm going to talk tonight about reverse shoulder replacement for massive rotator cuff tears. And just to kind of introduce myself, I'm from Sacramento. I went to Christian Brothers High School, and like Alberto mentioned at the beginning, I'm now the team physician for the football team, which is kind of fun. I did all of my most of my training down in Southern California at USC and at UCLA, and then I did a fellowship at UCSF in sports medicine and shoulder surgery. So, and I've been back in Sacramento for about 3.5 years now. So the goal for my talk is to try and have a better understanding about what a reverse shoulder replacement is, when we use it, expected patient outcomes. I'll kind of talk about how I counsel patients and what I tell them about what they can expect after surgery, how long the prosthesis lasts. And then I want to go over a couple cases about how I've incorporated new technology into my practice and how this has really helped me become a better surgeon. So just starting out to going over some of the bony anatomy here. Of course, we've got the scapula, the shoulder blade, and the glenoid here, which is the socket. We have the humeral head or the ball, and that's what articulates and forms the main shoulder joint. And so looking at this normal x-ray here, what I would draw your attention to is the socket itself, or the glenoid, is actually pretty flat. Unlike a hip joint, which is a deeper socket, the fact that the glenoid is flat allows the ball to rotate around it and have a wide arc of motion. And so, of course, what helps the ball move around is the rotator cuff. And so we'll talk a little bit about, and Dr. Hirahara already mentioned what happens to the shoulder when we have a rotator cuff tear, and how the superior capsular reconstruction helps to keep this ball centered on the socket. So when we look at the forces on the shoulder, the rotator cuff pulls the ball medially and keeps it centered on the socket. And this is the other main force on the humerus is the deltoid, which pulls superiorly. So you have the deltoid pulling superiorly, you have the rotator cuff pulling medially, and that's what helps keep the ball centered on the socket as it rotates around. Now, if you have a muscle imbalance, or in this case, tonight we're talking about massive rotator cuff tear, so they lost this ability to pull the ball medially and keep it centered. Therefore, the ball is going to raise superiorly and abut underneath the acromion. In terms of what a reverse is, it's a shoulder replacement that was FDA approved back in 2004 here in the United States. It has been used a lot longer, about 10 years prior in Europe. And it's called a reverse because it reverses the ball and socket joint. So here, normal articulation of the ball with the socket, and here we have the ball has been now placed on the shoulder, on the scapula, and the cup or the socket is now on the humerus. This is in contrast to an anatomic shoulder replacement. So there's two main shoulder replacements, the reverse and an anatomic. And so the anatomic just recreates the normal anatomy. The ball is still on the humerus, the socket is still on the scapula. And this is obviously reversed when we talk about the reverse shoulder replacement. And why I wanted to point out these two differences is they function very differently. So on the left-hand side with our normal anatomic shoulder replacement, we really rely on the rotator cuff to power the shoulder. So the reverse came around and it was really revolutionary because it did not require a functioning rotator cuff to work. And that was always the problem with these anatomic shoulder replacements, is that if you have a rotator cuff tear, this will not function very well. And so as Dr. Hirahara talked about pseudoparalysis, the patient's right shoulder in this case really isn't paralyzed, it's just acting like it is because it's lost its ability to rotate around the socket. And so as the deltoid pulls the humerus superiorly, it abuts underneath the acromion, causing pain, decreased motion and function. And so the deltoid, and so that's just kind of going over the normal anatomy. Now we'll talk about what really powers the reverse shoulder replacement, and really it's the deltoid. So on the left-hand side here, we can see that as the deltoid pulls the humerus up when the patient wants to lift their arm, instead of the humerus rising superiorly, it rotates around a fixed center of rotation on the glenoid, which rotates around this glenosphere. And so that's what allows the shoulder to move without a rotator cuff. And so I just want to touch kind of briefly on some new technology that's come out over the past couple of years. When I was in my training in residency at UCLA and in my fellowship at UCSF, we used conventional instrumentation. So, and, you know, there's quite a bit of degree of error when we use conventional instrumentation. And by using preoperative templating and navigation, we're able to really place these components in the exact spot that we think that they should go. And so this is just an example that I got from a review article that shows that the base plate has come dislodged from the scapula, and not sure exactly what was going on in this case, but perhaps this wasn't positioned in the best spot and it broke. And so two cases kind of highlight how this new technology has really changed. So again, I didn't train with this, but I started using this a few years ago, and it's really, really changed my practice and my ability to perform this surgery well. And I think it's really improved my patient outcomes because of that. I feel much more secure in the operating room with it. So looking at these x-rays here, nothing looks too abnormal. You have arthritis. The ball appears to have risen superiorly, indicating a rotator cuff tear. So, you know, I talked about a reverse shoulder replacement for this particular patient. And so I got a preoperative CT scan and then plugged it into the templating software, which is nice. It gives me a three-dimensional, shows me the anatomy three-dimensionally and allows me to kind of play with it. And I'll show on the next slide how I can put the implants on the shoulder and angle them certain ways to see if I can get them to fit appropriately. And so what I would draw your attention to in this particular case is how the glenoid is shaped. See how it's almost pointing backwards? Very small glenoid. And as you can see on the right-hand side, this is going to make it very difficult for me to place a base plate and put the glenosphere on. And so in this case here, I'm trying to rotate the base plate around, trying to fit it on the socket. But again, I have to rotate this thing almost pointing backwards, the screws pointing out the front. This would not fit. And had I not gotten the appropriate imaging and plugged it into the templating software, I would have utilized my conventional instrumentation, the conventional implants, and really would have had a catastrophic failure. I wouldn't have been able to do this case. And so I think that's what, most reverse shoulder replacements that are done now don't use this templating software. But again, it's pretty new and a lot of the different companies offer it. And I've really, really enjoyed using it because I think it's made me a better surgeon. And certainly in this case, helped me make the right decision, which is he needed a custom implant. So because of that, he gets a custom implant that can really be basically adjusted to fit his anatomy. This next case here, I just want to highlight in the middle here. I'll play this video here in a second, but I just want to show you, here's the glenoid or the socket where I'm trying to place this base plate here. You can see there's really not a lot of room for error. You have to be very precise with this. And as I scroll through here, if I'm off a few millimeters or off a few degrees, I'm going to place this base plate in an inappropriate position and risk having it break down the road. And so that's what's nice about this software is that you can really dial it in based on the patient's anatomy and really get a three-dimensional look and see where prior to going to the operating room, you can really come up with a game plan and feel very secure that what you're doing is appropriate for this particular patient and it's going to work. So when I counsel patients on reverse shoulder replacement, when is the right time? I think it's really important to understand what bothers them about the shoulder. As Robert mentioned earlier, physical therapy can be very successful in a large percentage of patients with rotator cuff tears. So even though a patient might have a large or what we consider a massive rotator cuff tear, they can compensate very well. What tips the scale and changes things is when the patient starts to have pain. So I always tell patients the number 1, number 2, and number 3 reasons to have a shoulder replacement is pain, looking for pain relief. It's important to understand in terms their limitations with their activities of daily living and what non-operative treatments they've tried. Traditionally, the indications for reverse shoulder arthroplasty are been for patients older than 70 years of age. I did a study that we published in 2018 that also looked at younger patients under the age of 65 and compared them to older patients. And we found that actually younger patients do very well as older patients with reverse and actually have better range of motion. The other main indications is arthritis. So arthritis on an x-ray, that's what differentiates doing an SCR or a superior capsular reconstruction like Dr. Hirahara talked about versus a reverse is if the patient has arthritis, they're going to do better with the reverse. Pseudoparalysis, again, if a patient can't lift their arm because of this massive rotator cuff, they can't compensate, then a reverse can really help them out. In terms of overall motion, again, these numbers are taken from the study that we published, and average forward elevation is approximately 133 degrees in the forward plane. External rotation is one of the most difficult ranges of motion to get back. On average, they get around 40 degrees of external rotation, and when we judge internal rotation, it's how far they can get their hand up their back. It's really important to tell patients that because they don't have a rotator cuff and because of the way a reverse shoulder replacement is designed, since the deltoid is what's really powering the shoulder now, it's not a great rotator. So rotating externally, rotating up the back, those are the more challenging positions to do or to get into. And in terms of counseling, I always demonstrate what that means because we don't want to, I want to make sure that there's no surprises after surgery in terms of what the patient can and cannot do. Physical therapy is very important. And during the first 6 weeks, I keep my patients in a sling. And the goal really during this first initial period is to prevent an early dislocation. Dislocations after reverse shoulder arthroplasty are catastrophic. It's a very big problem, usually requires a revision surgery to change how the components are placed. Then we begin active and passive motion at 6 weeks. And that's again to get our motion back. And then strengthening around 12 weeks. So that's when we talk about, the earliest return to sport is around, is as early as 3 months, but really it's about 4 to 5 months before they get back to golf and swimming. And in terms of longevity, in terms of how long the prosthesis lasts, if we look at revision as an endpoint, meaning having a revision surgery to change the prosthesis, whether it's loosening or a fracture or infection, 93% are still going strong at 10 years. And so I think it's important to understand these numbers and tell these patients that, because if you have a 55-year-old patient, even though we know they do very well with a reverse, it might not be their last surgery. So we think this prosthesis will last a long time. So far, the data shows 93% are still doing well at 10 years, but I can't guarantee that it's going to last 15 or 20 years. And as we follow these patients out longer, we'll have better numbers to educate our patients. In terms of outcomes, very good pain relief and patient-reported outcomes with reverse shoulder replacement. Satisfaction rates are over 90%. When patients ask, how likely am I able to get back to swimming or golfing? Depending on the study you read, it's between 60 and 85%. When we kind of break that down a little bit and look at what level of play they're able to get back, 65% at the same level, and 30% even actually achieve a higher level of play. So the reverse doesn't, just because you have a shoulder replacement, especially a reverse, specifically a reverse, it doesn't mean that they can't still do some type of physical activity in sports. Major complication rate is 15%, with infection being around 2 to 3%. All right, so in summary, I hope everyone has a little bit better understanding what a reverse shoulder replacement is, when we use it. Again, I think it's really important to assess how much pain the patient's having, because that's what's really going to be impacted by this shoulder replacement. Arthritis with a rotator cuff tear are musts. I hope that people have a better understanding about expected patient outcomes and their pain relief, how long the prosthesis lasts. And again, like I said, I didn't train with some of the technology that I showed during those 2 case examples, but it's come out over the past couple years. I've really looked into it and really adopted it. And this has improved my ability to accurately place the components. I think it's made me a better surgeon. And now, on every single shoulder replacement that I do, I insist on having that preoperative templating, and because it allows me to do a better job at the time of surgery. So thank you.
All right, great job, Dr. Leathers. That was very informative. Thank you so much for that lecture. We're going to open it up to a panel discussion. We'll start with you, Mike. Now, I know that you went over the expected range of motion of the shoulder. Is that an average? Do some people get more? And what about overhead activities? You mentioned a little bit about golf, tennis, things like basketball or throwing a baseball. Is that something that is an expectation after shoulder replacement, or is that something that likely they won't be able to do?
Yeah, so I think overhead sports are obviously going to be a little bit more difficult and challenging because the rotator cuff really is important for throwing a baseball, hitting a tennis ball overhead. So, but patients can get back to playing tennis. I think they just modify their strokes a little bit. But no, I mean, it's definitely a possibility, but overhead sports are what are challenging for sure.
And they were likely very challenging before the replacement, right? Because if they're getting that, they're probably already having difficulty. Okay.
And I think that's a good point because when I counsel patients and we talk about what they can and can't do after surgery, assessing what they can do before surgery, like you said, they couldn't, serve a tennis ball overhead anyway. So trying to give them some realistic expectations and what the main reason to do it, which is really pain relief, is number one. And then functional stuff is really secondary.
Perfect. Thank you. The next question was for Dr. Hirahara. Basically, they wanted to know about, this was from David Doran, and I know you answered on the chat, but what are the specific fixation points and how are they fixated? And maybe if you could give us a little bit of insight on how technically you do the SCR procedure and how long does it take you to do it on a normal basis?
So that's a good question. So the fixation points are on the glenoid and the tuberosity. So we're trying to reestablish where the normal capsule fixates. There's been a controversy as to whether or not people should retain the labrum, take out the labrum. I retain the labrum. I retain the biceps if I can. I will then fix the graft to the medial aspect of the glenoid, just medial to where the labrum fixates, using either 2 or 3 anchors. Whether we use just simply knotless fixation or knotted fixation is kind of dealer's choice. There's many different techniques now to how to do it. We have many ways we can do it. Laterally, we use double row techniques typically. Myself, I use a speed bridge configuration where it's double row, either 4 anchors or 6 with a medial double pulley to make sure that that holds it down and gets better compression of the graft over the whole bony surface. And basically the whole idea is just reestablishing the anatomy that was there as best we can. In terms of how I do it arthroscopically, so it's to all arthroscopic means small little holes. I don't have to open. However, if people have challenges doing that, it can be done in an open fashion. I actually think it's harder to do open than arthroscopic. I think it's actually easier. In terms of average time, it takes me about 1 hour and 15 minutes to do the case. It is done as an outpatient surgery. They do go home the same day. They're in a sling, and then that's kind of the way things work. Robert, actually, I think you should kind of weigh in about the therapy of how the patients do what they do, and your own experience with being able to get back to overhead activity in sports with an SCR. Because really, if we hadn't done that, you would have been stuck with the reverse, wouldn't you?
Yeah, thank you, Dr. Hirahara. You're exactly right. In my presentation, I wasn't able to go over much detail about my specific case other than I had one. And at the time of getting my SCR, I think I was the youngest in the cohort. So there was some decisions to be made. Dr. Hirahara was my surgeon, and so the decision was made to go ahead for longevity's sake, minimal to no arthritis, a person who wanted to go back to very active things. I think this was the best so that we reestablished some of that glenohumeral rhythm or motion. So I've found, as I've seen it treated and seen a number of these SCRs from Dr. Hirahara and from a few of the other docs nationally or around the state, that their pain levels decrease significantly in that first beginning 4 to 6 weeks as compared to some of the other traditional means of surgery. And then what I counsel a lot of our folks on is that you still don't have an intact rotator cuff unless they're doing the SCR with rotator cuff repair. So we have to just be careful on how much stress we put on that SCR over time. And so we do a lot of muscle balancing. We do a lot of anterior deltoid work. We work below the shoulder. But believe it or not, and Dr. Hirahara, you should put your computer on mute, but I went back to overhead lifting and throwing and sports, not advised by my surgeon, but I'm doing it without pain now. And I was having issues throwing and lifting overhead where it would affect my sleep. So kind of on a personal note, I'm a big proponent of this, especially if it's indicated. And it may not be for everyone, but especially if it's indicated.
Perfect. We have another question from Jessica Endo. It says, Dr. Hirahara, you mentioned one of the contraindications for the SCR is bone defects, but that one of the case you presented with that gal that had multiple surgeries actually had some bony defects. What made you decide she was still an appropriate candidate for the procedure?
That's a great question. However, I think it's just more important to understand what kind of bony defect we're talking about. So when I talk about bony defects, I'm talking about actually on the articular surface. So on the glenoid or on the humeral head. Those bony defects were actually intra-bone. So they didn't affect the structure of the glenohumeral joint itself. I actually did have to do some magic on those to make sure that the anchors fixated well within the bone. I actually ended up putting some dissolvable cement in there, and then I put the anchors into the dissolvable cement in the bone. And what's interesting, and that's actually been its own little case study that we have followed, because that was something that's innovative at the time. And I remember that our rep that was there for that specific product was very much against me using it that way because it wasn't to be done arthroscopically, and didn't think it could be done arthroscopically, and I did. And it worked out actually fabulous for the lady. But in terms of arthritis, that's really the key to the whole thing. And she did have a little arthritis on the top there. And that's what we've learned, is that if you have no to small amount of arthritis, that's good. But if they have bad arthritis, no amount of superior capsular constraint is going to help. And so if they've already lost their arthritis, lost their joint, that's where the reverse is absolutely indicated in that case. And that's where we have to be really careful with some of these younger people and not let them get to that point. We can't let them go so long where now they've destroyed their joint and now I can't do an SCR, because then they're going to have a reverse. And can you imagine someone at 40 or 50 having a reverse, which only lasts 10, 20 years at best maybe, and then having to have it redone? The complications are going to go up. So our goal is joint preservation. Our goal is to keep these people active as long as we can. And that's kind of our whole goal with everything we're talking about from the beginning here to end: therapy, SCR, and reverse.
Excellent. Thank you so much. We have another question from Gary Lentel, and Mike or Robert, if you guys want to tackle this, or we can get your opinion from both. Key guidelines to follow to minimize risk of catastrophic dislocation following reverse TSA.
Yeah, so I think that's why that's why the goal for me for the first 6 weeks is really to allow the soft tissues to heal and allow the shoulder to, the reverse shoulder replacement to scar in. Because, we've looked at early, getting patients moving early after reverse, and the initial the early dislocations occur within the first 3 to 4 weeks. And so if we can get past that initial 3 to 4 weeks, then they're much less likely to dislocate. So that's why I keep people in a sling initially. I'll let the soft tissues heal. That helps create a soft tissue envelope, which keeps the prosthesis stable. Because unlike a normal shoulder where you have rotator cuff, or with Dr. Hirahara, when Alan puts in the superior capsular reconstruction, there's a lot of stuff holding the ball into the socket. When you do a reverse, all you have is the deltoid still really attached oftentimes. And so because of that, it's much more prone to dislocating, and it's a big deal when it does. So that's why I go slow initially, allow the shoulder to scar in, and that creates a nice envelope for which to keep the shoulder in place.
If I can add to those comments, Mike, I completely agree, is letting that soft tissue really heal. And I think the goal for therapists and working closely with their orthopedic surgeons is to understand the mapping that goes on and understand the procedure that took place and what muscles were involved and how the tissue actually looked. And so we'll ask for op reports, we'll communicate with our orthopedic surgeons. I want to touch bases with them to make sure that the tissue was good, and then be respectful of the tissue and the protocol as the doctors have kind of done their work and taken them through to make sure they haven't over constrained or under constrained the repairs, and then we work from there. So I agree, it's conservative management, and obviously letting pain ultimately drive it. If it's painful, we probably shouldn't be pushing that. There's no bout of range of motion that should be gotten through pushing and prodding, and they're so sore afterwards.
Excellent. And staying with the topic, Dr. Leathers, when do patients see the biggest improvement after a reverse? And then maybe we could ask the same question after SCR once you're done.
Yeah, so I think the worst part after reverse is for sure that first 4 to 6 weeks while I keep them in a sling. That is the most constraining and difficult for a patient, but the pain relief is almost immediate. So the most improvement we've found is during the first 6 months after surgery. Actually, they pain relief almost instantly better, and then the motion as we get them moving 6 weeks to 6 months is when they're going to see their biggest improvement. They do see some additional improvement up to a year or two, but really their largest occurs during the first 6 months.
Okay, and Dr. Hirahara, could you answer the same after SCR? When do you expect the most improvement?
Well, so I'm gonna tag this on to one of the Q&As that just came up by Doug Sheeks asking about sleep, and I think this is an appropriate time to talk about that. I think the key to sleep, and the reason why rotator cuff tears hurt so much, especially at rest and sleep, is exactly why we want all these patients to go to therapy first. Because the issue is that therapy can make sure you balance the muscular tissues and the muscular strength to keep that ball centered, to be functional. If the ball is out of whack, if it's out of position, subluxed, you're going to have significant pain. And unfortunately, when you're asleep, that dynamic structural muscular control is gone. And so it is out of place, and it is able to slip out of position and then start to pivot up on the glenoid rim. You're going to have significant pain. And then also what you'll get is muscular spasm, which is another big part of the pain that people get. So the thing is, with small rotator cuff tears, moderate rotator cuff tears, and even large rotator cuff tears that are not retracted, you do not have functional loss. These people are able to manage, if they can balance their muscular tissues, you can get them back. And so that's why surgery is not always necessarily the answer. And that's why going to Robert first is critical to see if what he does can work. So that brings us into what kind of outcomes we see. Well, actually, I have patients that wake up from an SCR and they have no pain. And all of a sudden, like, all the pain they had is gone. All that nagging, aching pain, because now their head is back in position and it's being held in position. So these people wake up, they do better. In the first week, they're like, why am I in a sling? Can I be out of the sling? I feel great. And it's a problem for us because we have to hold them down not to do too much. But we have learned that with the SCR, there's far less pain. They do really well quickly. And it's amazing that recentering that ball makes all the difference.
Thank you for clarifying that, Dr. Hirahara. We have another question. I believe it's probably for Dr. Leathers, but this is from Chad Rickenberg. Is there any change in your guidelines when you notice a patient has issues with excessive scarring? Maybe both of you or all three of you could tackle this one.
Excessive scarring, I don't change. I guess in terms of scarring, I don't change things too much. It's hard to know, I guess, ahead of time how much scarring the patient's going to have. I think oftentimes you find that out after the fact when they're quite a bit stiff. But usually I reassure patients that stiffness will improve, the scar will relax and stretch out, but it might just take a little bit longer. And so again, that's where your therapist, I mean, they're vital to the process here of getting the patient stretched out appropriately. So that's what I would say about scarring.
So from my point of view, it's a little different. And with arthroscopic surgery, scarring is our biggest fear and it's our biggest problem. It's number one. And that's why all of my patients, no matter what surgery I've done arthroscopically on them, on their shoulder, they begin therapy within 5 to 7 days, everybody. And education and therapy is critical because once scarring occurs in an arthroscopic environment, it's very hard to reverse it. And if you let it go over a year, it's permanent. And they're going to then cause increased joint reaction forces. They're going to get arthritic changes. They're going to have severe pain. They're going to have achiness. They're not going to sleep well. They're going to have rest pain. And so they're going to never get their motion back. So we have 6 months to make sure their motion is 100% and good. And so we're very much on top of these patients from day one. So number one, we start passive motion immediately. We're cautious to make sure we don't overstress the repairs. And that's why you heard Robert talk about the communication between his office and mine to make sure that their therapists know exactly what we did and how we did it, what technique, what anchors, what fixation, so that way then the patients are taken care of day one moving forward and that we can minimize our risk. Also, because you're being seen by these guys every week, if they start seeing that someone's starting to have spasms, starting to get those scarring, starting to get those problems with motion, they send them back to me immediately, and then I send them to Dr. Pinero to do a dilatation.
If I can add to that quickly, Dr. Pinero, if I can add to that quickly, I think this is the importance of having establishing and having a rehab team that you trust and that you can have open communication about how your patient is progressing. And then not to forget that the patient is part of this rehab team, right? It's not the great surgeons. It's not the great PM&R sports docs. It's not the average therapist, as some of us refer to. It's that whole team approach that we really work towards. And the patient has to be a part of that in education. And we talked about the kind of 5 principles earlier. So I think this all comes with any type of surgery. And then we hope that reduces that amount of scarring early on. We do have folks that will develop it. We get a little more aggressive within terms of soft tissue work, but staying within the parameters or the precautions of not potentially putting that surgery at risk. So that's the big thing.
I couldn't agree with you guys more. I think the team approach is really key. We have a few more questions. Next is from Christopher McKnight. This is for Dr. Leathers. Are you seeking out a more lateralized and or inferior center of rotation for your reverses? What is the ideal lateralization for optimal range of motion?
Great question. So that definitely gets into some technical points here. So I'm just going to share my screen real fast just to kind of highlight where, the software, the templating software allows us to change some of those things. So what we're talking about is, where do we place the center of rotation of this ball? Do we leave it flat right on the glenoid? Do we offset it more laterally? What happens is when you have a reverse and it rotates around this ball, it can abut underneath and rub against the scapula here, causing notching. And so that impingement prevents range of motion, impacts range of motion and function. And so what we've done is we've changed the center of rotation and lateralized it. And what we think is that helps with some of our range of motion, especially external rotation. So we think having a more lateralized center of rotation is helpful. And then inferior offset. And what that means is, setting this so that it's not straight in the center, actually have it dialed down a little bit inferior. You can see that the ball hangs below. And by doing that, we think that's going to cause less impingement. You can see that the ball is offset here. And so it's also, I used a wedge here on this base plate, which again helps match the patient's anatomy without removing a lot of bone, therefore allows me to increase the lateral offset, hopefully allowing for better range of motion. But what the ideal amount of offset and lateralization is still to be determined.
Excellent. Thank you so much for clarifying that. We have another question from Thomas Hopkins. What factors are most critical in selecting a patient for a surgical option following rotator cuff injury? Is sooner better than later? I'll open it up.
That is a phenomenally great question. And there's multiple ways to answer that, unfortunately. So if it's an acute injury, it's better to be addressed sooner than later, in the sense of the sooner we get to it, and it will have less chance of retraction, less chance of fatty atrophy, less chance of loss of muscle mass. And so getting to that sooner than later is better. However, because it was an acute injury, they need to be in therapy right away, because in an acute injury, they're all going to have bleeding, pain, stiffness, inflammation. And so the therapists have to be the first stop. Now, it doesn't mean they should not see the surgeon relatively soon, but they don't need to see the surgeon first. They actually have to see the therapist first. Now, here's the next question. Do all rotator cuff tears have to be fixed? Well, that's the $1 million question. And I think that's the key to this whole entire discussion, is that on the one hand, if a rotator cuff tear never gets larger than what it was, then I really do think that it doesn't necessarily have to be done now. It can wait. And that's kind of the key. But if it gets larger, we have lost stuff, because the problem is having that tissue get larger, we know the chance of success goes down. So on the one hand, if you have someone who goes couch, fridge, couch, probably not a rush to get to. But if you have someone who's very active, very sports related, definitely probably someone you want to get to much, much faster. And even if they're older, in the sense of 60s, 70s, 80s, I will be more aggressive for those people, because I can't be an age hater. I have to listen to the patient, listen to what they want out of their life, what's inhibiting their lifestyle. And ultimately, there's the answer. If the patient is impacted, if the patient wants more from their life, if the patient says, no, I'm going to be around a while and I want this stuff better, well, then that's reasonable. So in the end, for me, the answer is the patient. But there's a lot of ifs, ands, and buts to that question. But the therapist is key to the whole thing as well, because they're going to give me a better outcome in surgery if I have better range of motion, less inflammation. Because if I go in with stiffness, they come out with stiffness and it'll be way worse.
Dr. Leathers, would you like to add anything?
Yeah, I would just, I think definitely you have to take into consideration, the patient, the age, what they can and can't do, and how they feel. Because certainly this is an elective procedure. And I think, Robert kind of cited the Moon group, which was a big a group of shoulder surgeons, and they compiled their data of rotator cuff tears. And what they found initially was that patients with full thickness tears, a large portion of them, greater than 75% of them, were able to be had very good results at 2 years with physical therapy alone. When they follow those patients out actually a little bit longer, and we see, okay, well, that's 2 years. What about 5 years down the road, 10 years down the road? They've actually found that those patients started to not do as well. And so when they compared them to having your rotator cuff repaired, those patients actually were outperforming them. So again, it's always up to the patient. You have to take them into consideration. But I think the data now has really started to show that long-term, it's better to have your rotator cuff repaired. So if you can fix it, I think we'd all like to do it earlier rather than later, because it can become unfixable if you wait too long. For me, when it comes to talking about shoulder replacement, that is something where we really have some time on our hands. This is not something that we need to rush into. Whether it happens now, 5 years down the road, 10 years down the road, it's still possible. So that's where, for me, counseling the patient and making sure they've tried physical therapy. Because if they have a rotator cuff tear that's too big to fix, or they have a little bit of arthritis, too much that you can't do an SCR, then I'm in no rush to do a reverse until they have pain and disability.
Excellent. Thank you. We have a couple more. One is, how does nerve damage and muscle atrophy affect rotator cuff injuries? And does the surgical management change if that's a fact? And then another follow-up question is, what is your guys' feeling about cortisone injections and rotator cuff tears and an arthritis before SCR and before doing a replacement?
So for me, nerve injury and assessing the function of their deltoid is critical, because the deltoid really is everything when it comes to powering the shoulder, the reverse shoulder replacement. So if they don't have a functioning deltoid, a reverse really isn't going to work for them. So that's very important. When it comes to cortisone injections, definitely, there's a lot more research that has come out showing that cortisone injections around the time of shoulder replacement, or really any joint replacement, increases their risk of infection. Dr. Hirahara can talk about the SCRs and after a rotator cuff repair. But yeah, we try to avoid cortisone certainly within 4 to 4 months or so of doing a shoulder replacement.
So actually, I completely agree with everything Mike just said. And actually, the data on cortisone is becoming, as he said, since 2017, 2019, really, really persuasive that it just shouldn't be done. Cortisone can not just increase your risk of infection, but decrease your risk of healing. And it also inhibits our repair. And we've shown that with cortisone shots within a 1 to 6 month time period before rotator cuff repair, has a significant increased risk of re-tear and failure. And so I think the key that I would want to tell all the docs out there is that if you're going to send someone to me for consideration of repair, please don't shoot them with cortisone first. So if you don't plan to have that person have surgery for the next year, cool, go for it. That's fine. But if you have any thoughts that they're going to need surgery in the coming year, please don't shoot them with cortisone. Let me have a discussion with them first if we're going to consider fixing it or not. So, things like platelet-rich plasma, amnion stem cells, that's fine. It's not going to impact my surgery at all. But cortisone specifically is just a no-no.
Okay. Robert?
Yeah, thank you. I want to touch a little bit about nerve injury, and not specifically, what do we do to treat nerve injury, but as a therapist, I want to know if there is nerve injury. And so if the doctors are ordering an EMG, I want to know the outcome of that EMG study, because that's going to affect how aggressively I go after strength training for those specific muscle groups. So it's paramount for us to understand the diagnosis and the diagnostics test, That's why I recommend reaching out to your surgeons and getting a full understanding of what you're dealing with. Is it a massive rotator cuff tear with nerve damage? Is it a smaller tear, and which can be oftentimes more painful than large tears? And so understanding that portion of it then allows us to determine where we're going to focus our treatments and where we're going to focus our strength training. So I think that's really, really important to understanding the full diagnoses.
Okay, excellent. Would anybody like to add any closing comments? Okay, excellent. That was such an amazing presentation. I thoroughly enjoyed it. I hope all our viewers did too. With that, I'd like to thank everybody. I know we have a lot of people watching, not only in the US, but around the globe. So thank you for that. You will get a short survey after the presentation's over. If you could please fill that out. That information really helps us not only improve, but also see what other topics people would like us to discuss. So with that, I'd like to thank everybody. Have a great night and look forward to chatting with you guys on the next one.